Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During today's webinar, please feel free to type in your questions at any time, but note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Surgical Management of Cushing's Disease, is being presented by Dr. Russell Lonser. Dr. Lonser graduated with a BA in Economics from Andrews University and received his MD from Loma Linda University. He completed his neurosurgical training at the University of Utah. During his residency, he performed a 2-year research fellowship under the mentorship of Dr. Edward Oldfield in the Surgical Neurology Branch at the National Institutes of Health. Upon completion of his residency, he joined the staff of the Surgical Neurology Branch at NIH. He was chief of the Surgical Neurology Branch at NIH before becoming professor and chair of the Department of Neurological Surgery at Ohio State University. Dr. Lonser's research interests include development of drug delivery paradigms for the central nervous system pathology, as well as investigation of tumor pathogenesis and biology. His clinical and surgical interests are centered on the treatment of brain, temporal bone, and spinal cord tumors. He is an author on over 300 scientific and clinical publications. He is a co-inventor on a patent for methods for convection-enhanced delivery of therapeutic agents. His contributions to organized neurosurgery include membership on the Executive Committee of the Congress of Neurological Surgeons. He was treasurer of the Congress of Neurological Surgeons and is president of the Congress of Neurological Surgeons. He also served on the Executive Committee for the American Association of Neurological Surgeons, Congress of Neurological Surgeons section on the tumors. He is head of the Research Subcommittee and Head, Neck, and Spine Injury Committee for the National Football League. He has been actively involved in the mentoring and training of over 40 neurosurgical fellows. He is on the editorial boards for Neurosurgery, World Neurosurgery, and the Journal of Neurosurgery, and he is also a member of the Pituitary Network Association. Dr. Lonser, thank you so much for your involvement with the PNA's webinar program. There will be a brief delay as we change presenters.
Thanks, Tim.
So you should see it on your end to accept.
Okay. There. Can you see me now?
Yep, I can.
So thanks, Tim. I appreciate the opportunity to speak on this webinar with the PNA. It's a phenomenal organization and super honored and delighted to be part of it and part of this series. So I'll just start. As you can see, the topic that I wanted to talk about is something that, Ed Oldfield, who recently passed away, and I worked together for 20 years. Many of those years were spent treating Cushing's disease at the NIH, and more recently now at Ohio State for myself. And while I'm going to talk primarily about the surgical management of Cushing's disease, I'm going to also talk about the biology behind it, the diagnosis, as well as some of ways to treat it in cases where biochemical remission after surgery may not be successful. Cushing's disease is very unique and dear to the hearts of neurosurgeons because Harvey Cushing founded the neurosurgery as a specialty in 1905. And Cushing's disease, as is clear, was named after him. And in fact, Cushing in 1910 wrote an article about mini G, you see pictured on the right, and these are pictures from his original text. And he very clearly described the clinical manifestations of Cushing's disease, and we'll get into that in just a bit. And he had hypothesized at the time that Cushing's disease was a result of a pituitary tumor. It was very controversial. It wasn't until 1970 when Jules Hardy showed that adenomas of the pituitary gland could cause Cushing's that it was actually accepted. And in the period of 60 years, it was not accepted that these were necessarily part of the pituitary gland or a problem with the pituitary gland in Cushing's disease. This is just a little bit of a timeline to kind of show you how our understanding of Cushing's evolved. It started, as I mentioned before, with Cushing in 1910 in his famous monograph on the pituitary and its disorders, where he hypothesized again that Cushing's, or the disease named after him, was caused by a tumor of the pituitary gland. His trainees, Pattison, based on Cushing's theory, began in 1933 placing radiation seeds in the pituitary gland. Had mild to moderate success in a couple of patients that were cured of Cushing's after placing these radiation seeds in the pituitary gland. Nevertheless, they had hypopituitarism. And it's interesting to note that while Cushing and his disciples did treat the pituitary, Cushing never actually operated on the pituitary gland in a Cushing's patient. Later, Nafziger, who was UCSF in the 1930s, instead of placing radiation into the pituitary area, he just removed the pituitary gland and had cured a handful of patients as well. Oliva Krona in Sweden burned the pituitary gland in Cushing's patients, and again had some success in just a handful of patients. For a number of years, though, afterwards, there was a great deal of criticism around this approach and the idea that the pituitary or a tumor in the pituitary was the source, and for about 20 years it was not believed to be the case. It wasn't until Jules Hardy in 1970 presented a paper at the National Institutes of Health where he described 10 patients that he had operated on with Cushing's disease and removed a very discrete tumor, and he described it similar to removing the red portion, I don't know the exact name for that, of the olive in a martini, and these patients ended up being cured for prolonged periods of time. It was the first evidence, clinical evidence, that in fact Cushing's disease was indeed from a pituitary adenoma as we know today. Ed Laws and Charlie Wilson popularized the approach, the transphonoidal approach to the pituitary, and we began to learn more and more about pituitary tumors, including those associated with Cushing's. And finally, Ed Oldfield and John Dotman and others developed petrosal sinus sampling, which to this day is the most sensitive and specific test for diagnosing Cushing's. We rarely use it, as we'll get into later, except in cases where there's an MR negative or no evidence of a pituitary tumor in a Cushing's patient. So what's the biology behind Cushing's disease? And this has been well studied and elucidated by endocrinologists, surgeons, and internists. If you look at the normal process or control of the pituitary gland, you see that ACTH is secreted during the pituitary gland, and it drives the adrenal gland to secrete cortisol. Cortisol goes back to the pituitary and hypothalamus and causes suppression of corticotropin releasing hormone, or CRH, as well as ACTH. And under normal circumstances, as cortisol levels rise, the secretion of those two hormones from the hypothalamus and pituitary gland are suppressed. In Cushing's disease, the problem is the tumor of the pituitary gland autonomously secretes ACTH without much or any control, and that ACTH stimulates the adrenal gland to secrete cortisol. The normal negative feedback of the cortisol on the pituitary is not successful, and the ACTH is continuously secreted throughout the day. Normally there's a diurnal variation where in the morning the cortisol levels are highest and in the evening they're the lowest. That is lost in Cushing's disease. The pathobiology underlies some or all of the clinical features. And if you begin to look at this from an epidemiologic standpoint, it's a relatively rare disorder. About 40 people per million will have Cushing's disease. There's an interesting feature that we don't have an explanation for. When you look at Cushing's disease patients that get it during their childhood years versus those that get Cushing's disease during their adult years. In the pediatric population, the male to female ratio is 1 to 1. In diagnosis, typically in the pediatric age group, is about 13 years of age. Now, I know myself and Ed have operated on children as young as 4 years of age in that pediatric group. When you look at adults, it's striking the difference between the male to female ratio, where in children it's 1-to-1. Females get Cushing's disease 4 times more frequently than males, and the average age of diagnosis in females is 30 years of age. In males, it's a bit older at 37 years of age. And again, we don't have an explanation for these differences biochemically or biologically. The features of Cushing's disease, as we saw in the original pictures from Cushing, mini G, have been well documented. The most common features in the childhood or pediatric group is rapid weight gain, obesity, and decreased linear growth. In those in adulthood, it's rapid weight gain, a dorsal or subclavicular fat pad, or development of that, and because it's far more common in women, amenorrhea or disruption of the normal menstrual cycle is the most common. But you can see other features such as the diabetes, hypertension. Cortisol is a potent immunosuppressant, so you can get infections, thin skin, bruising, skin ulcers, and you get an osteoporotic type picture. You can have the rounded faces, thinning hair, and what we do, because what happens also is because cortisol is a very potent steroid that we use steroids to shrink and reduce edema. You can also see cerebral atrophy, and many at the NIH are continuing to study these changes on imaging. This is an example of one of the identical twins that Ed had operated on over a number of years ago. And you see one of the common features is that decreased linear growth. And you can see these two identical twin children had very normal growth and appearances for a number of years until they reached the teenage years. And here you see the unaffected patient versus the affected patient. And again, unaffected, affected. And here's these two individuals or twins. This is after surgery, but you can still see that because of the decreased linear growth, it had a potent and lasting, in fact, impact on this identical twin patient who didn't catch up over time. So there is potent effects that impact the pediatric age group, even with complete remission of the disorder. Why are we so concerned about Cushing's disease? It's a very obvious question in the context of we're concerned about the effects of the disease, but even more importantly, if not treated effectively, it has an increase in mortality. Now, if you look at patients with persistent Cushing's disease that isn't treated or managed, they have a 5.5 times higher rate of mortality compared to others in the same age group. Once the Cushing's disease is treated, the mortality rate returns to normal. 1.2 is the standard mortality ratio for those that are in remission. And in fact, what's even more interesting and recently published is those patients that have a surgical remission, those that underwent a transfemoidal operation and were cured, their standardized mortality ratio goes to a little bit better than the age-matched population. But what's actually interesting and we don't quite understand is those patients that are under remission medically or through bilateral adrenal alectomy, where you remove the adrenal glands so they can't secrete cortisol, their standardized mortality ratio is 2.5 times the normal age-matched group. So it's very important that surgery is effective because it does have some benefits over some of even the medical therapies. And this is an area of interest and Ed and myself have had, as I mentioned before, in understanding how to improve the surgical side of the treatment of this disease. So how do we diagnose this? You saw the clinical features. Those clinical features, that syndrome, that appearance should prompt a number of studies. It starts with some very basic studies that include, and this is work done by Lynette Neiman at the NIH and her endocrine group guidelines that were published recently, and that includes looking at a late night salivary cortisol, 24 4-hour urine-free cortisol and doing a low-dose dexamethasone test to see if any of those are abnormal. And in most cases of Cushing syndrome, those features you saw, it's because people are taking exogenous steroids or have some other factor. It's not necessarily from a tumor within the body somewhere causing that secretion. So once you determine that you have the Cushing syndrome, which can be from the adrenal gland or the pituitary gland, now 80% of these are from the pituitary, that are ACTH dependent or dependent pituitary, you want to check an ACTH level. If it's low, it means that it's most likely from an adrenal source because the pituitary gland is being suppressed. In those cases where there's a high ACTH level, you have to be very suspicious of a pituitary or ectopic source. And the vast majority, though, of patients with a high ACTH level is from a pituitary source. And we do additional testing to confirm if it's pituitary or from a tumor of the lung or some other part that's secreting ACTH. And we do a high-dose dexamethasone test, which should be suppressed in Cushing's disease, suppresses the cortisol. A corticotropin-releasing hormone, or CRH, stimulation test, which should stimulate additional ACTH and cortisol in the pituitary setting. And we also do an MRI to see if there's a pituitary adenoma present on that scan. Now, interestingly enough, when you get down to this level, there's often some complexity because in Ed and my experience at the NIH and at OSU, 60% of the patients that were referred to us didn't have any imaging evidence of a pituitary tumor, and we had to do additional testing. And then, now, based on these initial tests, you can diagnose an ectopic source if you don't have the suppression or the excitation by CRH, and you can see a lesion somewhere else. And sometimes all these tests match up, and you see an adenoma on imaging, and you know you have a pituitary source. Many times there's, or at least half of the time or more in our series, we did not see a tumor on the pituitary gland, and we had to do inferior petrosal sinus sampling. And what that does in a very sensitive and specific way is if we put using an selective catheterization of the petrosal sinuses, which are veins that drain the pituitary gland, and we stimulate with CRH, we can see that the proximal blood that is drawn right near the cavernous sinus near the pituitary gland, when we compare it to peripheral blood, we see a 3-fold or higher amount of ACTH in those situations, and that's very diagnostic, even in the case where you don't have imaging evidence of a pituitary tumor for Cushing's disease. And so that's kind of the algorithm we work through to make the diagnosis of Cushing's. It's important to define it so that you're operating on the right organ. And here this just recapitulates the process of how to go through and make that diagnosis in the vast majority of cases in a definitive way. So surgical treatment. This is the first-line gold standard for patients with Cushing's disease. It's obviously not for every tumor, but Cushing's disease is one of the subset of pituitary tumors where surgery is the first-line treatment. And why is surgery the first treatment? And there's two very important reasons. One is it's immediately effective when we're successful. The other is, in the vast majority of cases, it preserves the pituitary function and doesn't cause partial pituitary dysfunction or complete pituitary dysfunction in the vast majority of cases. Now, there's 3 scenarios surgically, and you see them listed by and represented by these MR images of the surgical management of Cushing's disease. In this first, and this is just, these are post-contrast MRI images in the coronal plane, and you see the pituitary gland here, the carotid arteries here, cavernous sinus. And in this case, this is the case as surgeons, if we're operating on Cushing's or need to, this is the case we want. Here you see this nice white pituitary gland, and in this area, this dark area is a very well identified pituitary tumor. This is a case that's far more difficult, and this occurred in over half our cases we operated, where we don't see a tumor. It looks like typical normal gland all the way through. And then there's a case that's can be difficult, and we'll talk a bit about it in a little bit, where you have a larger tumor, and it's right up near the cavernous sinus wall shown here, and it looks like it possibly could be invasive into that wall. And we'll talk a little bit about how we surgically manage that. But we'll go through each of these scenarios because it will give some insight into what we're thinking as surgeons and the management paradigm moving forward. So let's start with the easiest case, and that's the one on the left where we see the MR imaging evidence of the tumor. We do a transsphenoidal. It can be done endoscopically or microscopically. Ed and myself favor the microscopic approach because we could get excellent visualization and 3D stereoscopic view. And these tumors don't tend to be large where an endoscope can help you with a tumor that's extended up above the pituitary and laterally or inferiorly where you need more broader exposure. And so what we would typically do is we'll remove the face of the gland, or the bone over the face of the gland, and here we're just cutting, this is the pituitary. We're cutting that very thin layer of dura, and we're separating it from the pituitary gland because we want to be exceptionally careful that if there's any invasion of that dura, we remove it because we don't want to leave cells in that area. And you can see that we're stripping that dura away from the face of the gland. This gland from side to side is about 1.5 centimeters, just to give you some perspective, and from top to bottom is about 1 centimeter. And you can see we're very gently stripping away that dura from the capsule of the actual gland, and you see the tan pinkish gland beneath. And there you go. And you can see, in this case, just like the imaging shows, you can start to see the outline of a tumor there. And then what we do is we make a very discrete, sharp opening at the edge of that tumor, because there's what Ed Oldfield defined a number of years ago was a histologic pseudocapsule. And all that means is that as the tumor gets larger, it compresses the pituitary gland, and you see it here. These gray lines are reticulin fibers that are very firm, and it creates a beautiful plane, as you can see, for us to work around systematically. And here we are just continuing around this very discrete tumor. And by doing that and using that pseudocapsule, it permits us to identify areas potentially of dural invasion that we would remove. And if we don't see those or feel those, we just simply remove the tumor in one piece. As you'll see here, we take it out, and even before we leave the operating room, we know this patient will have a successful cure. You see a very discrete tumor coming out right there. The second scenario is more complex, as I mentioned before, where we don't see a tumor on MR imaging. We have two things we can do in that case. We'll make vertical incisions through the gland. We'll search for that tumor. And in most of those cases, we'll find a very discrete tumor. We'll remove it using that pseudocapsule, as we showed on the previous study. And here's a case of where we excise through the gland, and sure enough, after making those vertical incisions, we see a tumor here, which was simply removed in the way we demonstrated just a little bit ago. Sometimes we don't find that tumor, and it's in about 4 to 6% of cases in our experience. And what we do, and what we have done, has been done in the past, is use the gradient of that petrosal sinus sampling. And so when we have those bilateral catheters up near the cavernous sinus, we can sometimes see a gradient. A number of years ago, Ed had published a paper in New England Journal showing that if that gradient was 1.5 times or 1.4 times higher on one side versus the other, then there was a high degree of likelihood that the tumor would be on that side, even if you didn't see it. What we subsequently found, this is data we looked at more recently in 501 patients, we found that predictive value wasn't 100%, and in fact, it was 69%. So we don't necessarily rely on that lateralization with the petrosal sinus sampling as much as we used to. In fact, when we looked at various ratios up to 100:1, we didn't see any advantage. And it's probably because there's bilateral outflow from both sides of the gland that may confuse that picture. When we look at, sorry, I'm going to go back. When we look at various ways to manage that, and so as I mentioned before, a number of 20, 30 years ago, we would just remove the half of the gland that had the higher gradient. Now, as the data I showed you doesn't really show that, it's about 69% accurate. We now remove 75% of the gland, and you can see that 75% is shown by the stippled area. We leave the top and superior lateral aspects intact, and that maintains pituitary function in 85% of patients, even removing that much gland. Now, when we look at the various approaches, the total removing all of the gland, half of the gland on the IPSS sampling gradient, or the 75%, which we do now, what we found is there's no difference in remission. Each of those, and you see all the data below, showed about 2/3 of the patients were cured of their Cushing's, no matter what you did. The problem with the removing of the whole gland, as you can imagine, you lose pituitary function for life. Removing half the gland or removing 75% of the gland, about an 85% chance of successfully maintaining function. So this is the approach we now use, and we evolved from this approach previously, the half of the gland, to removing just 75% in the area I showed. The final scenario is the one where we think there's some invasion of the cavernous sinus near the carotid artery. And this is something Ed and I were probably unique for a number of years, and maybe still in our approach to this, is we systematically remove the cavernous sinus wall to effect cure. And here's an example of a tumor here, right on the cavernous sinus wall. And what you see is we resected this, including the cavernous sinus wall, and you see that we found a tumor, and here's the cavernous sinus wall, that dura, and it was invading, and this is why we think it's important, so that you don't leave tumor in that dura because of distant recurrence and maybe even lack of remission. So how do we determine cure? We looked at this in over 200 pediatric patients as well as several hundred adult patients, and what we found is one of the most important positive predictors of lasting cure, meaning greater than 5 years, was a cortisol in the morning of less than 1 after surgery. And this had a 96% positive predictive value. You can see that many of the other tests, such as urine-free cortisol for 24 hours, as well as low ACTH levels, have very strong positive predictive values. So there's a number of good ways that are related to cortisol in the urine or in the blood, or ACTH levels that can tell you predict cure. Most people do use cortisol, and we've evolved as well into using immediate post-op cortisol levels, and we've published on the rapidity of the drop in those levels often will dictate lasting cure. The results after surgery are variable. You can see recurrence rates, and these are modern, last 5 years. Rates of recurrence anywhere from 7% to 5% to 66%. You can you can see remission rates of anywhere between 38% and 95%. A lot of it's based on surgeon expertise, because these are relatively rare tumors. They have features that are different from growth hormone adenomas or non-secreting pituitary adenomas, based on they have a very potent effect when they're small, and they can be often difficult to find or image. So surgeon experience does play, and volume plays an absolutely critical role in success in treatment. When treatment is effective, you don't need many, well, the blood tests are helpful. You can see the impact of it. This is Jules Hardy's first patient, and you can see he has maintained cure now over 50 years later, and Jules was kind enough to send this to show, but you can see the potent effect of successful treatment. Complications are rare. 5 to 10% of patients will have most of the time very minor transient complications, including diabetes insipidus, SIADH are most common in some patients, particularly with redos, and there's less than a 1 or 2% mortality, and that's consistent with all types of pituitary surgery. One of the complications that is common in children after surgery, even after successful surgery, is patients can get what's called pseudotumor cerebri, which is because of, it's like, we can see this after removing patients from steroids. We aren't entirely sure why it occurs, but they can get an increased intracranial pressure that sometimes we will often have to treat with either shunting of cerebrospinal fluid to reduce that pressure. Nevertheless, it's a very manageable effect and oftentimes doesn't require any additional surgery. So what are the factors that affect cure? There's 3 really that we've identified in our series. Between Ed and I, well over 1,000 or over 1,500 of these patients. 70% done by Ed, 30% by myself. Preoperative imaging findings, the lack of a tumor on imaging is associated with a reduced cure rate in some cases. The invasion of that dura around the sinus, if it's not identified and resected, can be associated with lack of remission. And small adenoma size can impact it, because remember we talked about that pseudocapsule, and we needed a certain size tumor, greater than 2 millimeters, to get that pseudocapsule. Otherwise, as you saw in that tumor, it appears very much like the gland. It's in fact the same color as the pituitary gland, and we can't identify them if we can't feel for that capsule. And this just shows data from a number of other groups. First of all, if you don't see the tumor on imaging, there is a significant decrease, and this is Ivan Chirik's data. You can see a significant decrease in cure immediately after surgery. Imaging can be improved. We use a spoiled gradient recalled acquisition study, or a VIBE technique that's common to all centers. And what we found is it had a 15 to 30-fold increase in detection of these adenomas. Here's a case where we used standard dynamic pituitary imaging, which is commonly used. You don't see a tumor in this case, but when we use the VIBE technique, you can clearly see a tumor. So some very simple things you can do to increase the odds of seeing these tumors and ultimately increase the odds of cure. Dural invasion, as I mentioned, we did a prospective study of 87 patients. We found that the dura was invaded even with small tumors in 34%. We could not determine, or MRI could not determine accurately which patients would have invasion. In fact, it was only accurate 22% of the time. And so we can't rely on that to determine invasion. It really has to be through careful surgical exploration that is determined. While we saw that invasion was more common with larger tumors shown here, you could see dural invasion could occur with very small tumors. So no matter what size these are, we're exceptionally careful about identifying areas that could be invaded and removing those as well. As I mentioned before, small tumors size is associated with a more difficult cure, and the reason, as we mentioned, you see these are 1 millimeter tumor diameters, 2 millimeter, 3, 4, and 5. You can see that below 2 millimeter tumor diameter, which is about the size of this dot, we don't have the pseudocapsule, and without that pseudocapsule, we don't have that very discrete border to guide us, and this is where sometimes we do have to remove portions of the gland to obtain a cure. So what happens when a patient undergoes surgery and doesn't have a remission immediately after surgery? We go through a very systematic algorithm, because we know lack of remission after surgery is caused by 4 scenarios. First is we didn't remove the adenoma or tumor that was causing it. We removed something else. 15% of the population has an incidental pituitary adenoma on imaging. We may have removed an abnormal appearing site that was not an adenoma of the gland. We may have incompletely removed the adenoma, which is rare when we get, as you can see by going around using the pseudocapsule, we can very discreetly define it, but it can happen. And an invasive adenoma in the dura or in the cavernous sinus was incompletely removed. So we know those are the 4 reasons based on looking at our surgical experience. And this is what we do then afterwards if we don't have remission. We repeat the imaging. It's unlikely that we will find a tumor, but very rarely we can. We serially section the specimens that we sent to the pathology lab to see if we can detect an area of ACTH adenoma. And that helps guide us to where we should go during the reoperation. We reoperate on these patients within 21 days generally. We call it an early reoperation because that allows us to get to the gland in a very unobtrusive way, an unscarred down way, and because scar is not formed within the gland, we can very discreetly find and re-explore the gland without much disruption or difficulty. And so the scenarios that we can see sometimes, if we see we repeat the MRI after the first surgery and we see the adenoma, we go right there, resect it, those patients invariably are cured. Sometimes when we don't see that, we go through the pathology and we'll see positive ACTH staining. We'll go to where we documented that site to be, because we're very careful in the operating room about documenting where we're taking tissue from, and we'll resect in that area, guided by the pathology. If we don't have any imaging evidence or histology, we'll go back and we'll do the partial and almost never the total hypophysectomy. We'll do that partial hypophysectomy or removal of the pituitary like I explained before after we re-explore the gland. And if there's no cure, we'll head to adjuvant therapy, medications, and radiation to the pituitary gland. So what if we cure a patient immediately after surgery and years later, which can happen in Cushing's disease, we have a recurrence? And we've looked at this very carefully in how to manage this, and we've done MR imaging. If there's an adenoma present that's recurred, we go back and resect it if possible. If not, we'll provide adjuvant therapy, which includes, again, radiation and medical therapy until the radiation takes effect. If there's no adenoma on imaging, we'll explore the site where the prior tumor was removed that affected the cure the first time. And that's the case. We rarely go to adjuvant therapy. Afterwards, we'll typically explore all of the patients that in that scenario. And the reason we explore them to the site was based on some data that Ed and Rob Dickerman published almost 16 years ago. And what they found in 68 patients out of over 1,000 that required reoperation, 95% of the recurrent tumors were found precisely at the site where they had removed the ACTH secreting tumor. There's either invasion or there was in very rare cases a remnant of tumor left. The vast majority are due to invasion of the dura, specifically invasion of the medial cavernous sinus wall. And so that's easily curable in those scenarios. So what happens, if you look at our series and a number of other series, the cure rates after surgical pituitary intervention push up into the mid to high 90s. But nevertheless, there are anywhere between 5 and 10% that do not have cure, and we need to explore adjuvant therapy. Patients can be put on a number of medical agents that either block the production of cortisol, block the action of cortisol, and these patients undergo radiation. But the medication is used to temper the effects of the increased cortisol in the Cushing's disease patient until the radiation can take effect. Now, Gamma knife is most commonly used because it's a one-time dose. Fractionated, the kind of conventional where you go in for several fractions 5 times a week for 5 weeks, 4 weeks, 3 weeks, depending on what your radiation oncologist likes, has a very similar remission rate. It's the one-time dosing and ease of that makes the stereotactic radiosurgery such as Gamma knife and the LINAC, linear accelerator, very commonly used entities to manage Cushing's disease. They're quite effective. The Gamma knife in the 70% range. from the published literature. Some of the downstream problems, though, with the gamma knife is there be partial or complete loss of pituitary function years down the road and need supplementation with exogenous hormones. So what are we doing now to avoid having to, those patients that don't get cured by surgery? How are we avoiding that outcome? And there's several things we've been working on at the NIH and at Ohio State. And that is, we're getting better imaging. We've developed a coil that you can place right on the face of the pituitary and get incredibly high resolution scans down to 400 nanometers. And we're hoping to deploy that soon in patients. We've published the outcomes of that, not in patients, but in cadavers that we've imaged. You can see some of here's the imaging in the coronal and sagittal plane, and compared to the histology, we can see incredibly small areas that were undetectable with even the best conventional MR imaging. So we're hoping that will help us in the operating room go directly to defined sites of pituitary adenomas that we can't see in using typical or available techniques outside of the operating room and outside of having this coil available. We're also looking at PET scanning as a way to identify these tumors. We're stimulating them with CRH and to drive them metabolically, and then we're looking at metabolic PET scans to see if that helps us identify the tumors. Again, imaging is such a critical piece, and if we can identify imaging, the cure rate goes into the very, very high 90s, 97, 98% cure rates if we can see them. So these are some of the new evolving areas that we're looking at improving. When you look at the totality of Cushing's disease, there's several kind of standout things, high-level view things, and those include surgical resection as a treatment of choice. It has been and remains that. The pseudocapsule I showed in that surgical video is critical for the effective resection. It ensures complete resection. It allows you to identify dural invasion that you can remove. While we can't prove it directly, I believe that resection of dural invasion is critical, including the cavernous sinus wall if it invades there to have lasting cure. And long-term follow-up is absolutely necessary. Recurrences can occur greater than 5 to 10 years out, so it's absolutely important that patients follow for the long run. Many times if there is a recurrence, it can be identified just clinically even before blood testing, which is also essential to identifying that recurrence. So I want to thank the PNA and everyone on this webinar for the opportunity to speak today. I'd be delighted to answer any questions.
Thank you, Dr. Lonser. That was excellent. There are a few questions. You mentioned about the importance of a pseudo capsule. Would there be reasons to wait on a tumor that's really small to allow it to get a little larger to develop that, or would that cause more problems? Yeah,
so that's a great question, and we would never wait to treat them because of the potent effects of the potent endocrine effects of the tumor that can cause significant morbidity and shorten life. These tumors, compared to a growth hormone secreting adenoma, which can take anywhere between 4 and 10 years to diagnose, the time from symptom formation to diagnosis in Cushing's disease is 4 years, much shorter, but the average size of a pituitary adenoma in Cushing's disease when at diagnosis is only 5 millimeters. And the reason they're so small compared to the growth hormone adenomas and other non-secretory adenomas, why you get the macroadenomas in those situations, and you don't typically have that in Cushing's disease, is because the biologic effect is so potent. And so we want to attack that as soon as possible.
Okay, thank you. Imaging, this improved imaging that you've mentioned, how widely is that available across hospitals? Is it only in specialty pituitary centers, or is it available nationwide?
It's available nationwide. The VIBE technique, or that SPGR technique, is available across all platforms virtually. I would guess in probably every hospital with an MR, it's available. It's just sometimes not known because a lot of the, again, because most of the tumors, the prolactinomas, the growth hormone secreting tumors, the non-secretory tumors are detected when they're larger. So you don't need that very unique kind of imaging set, but it's very easily done at any center.
Would you recommend that patients ask for that if they,
Yeah, and it's hard. It will, because it's rare enough. It may create some confusion, but I think they should. And I think that if they go to any center that does a lot of Cushing's disease, it's one of those things that will be understood by those centers. Whereas a center that doesn't do a lot of Cushing's may not use that imaging technique, but I don't think I think it's very reasonable for a patient to ask for that.
Okay, excellent. What is the definition of disease-free after surgery?
So it's a biochemical remission is what we call it. And that is where the patient, because what happens with these pituitary adenomas is they suppress the gland from secreting cortisol. So when we remove that, or ACTH, when we remove that ACTH secreting tumor, the gland remains suppressed for a long, and patients will need hormonal supplementation and cortisol and things like that. But what that does is we can very accurately tell if we've created that remission. And the way we tell it is by removing that secreting tumor of ACTH. What happens is the cortisol crashes to non-detectable amounts, and that tells us that we've had the biochemical cure, and that portends success even in a lasting period of time in the vast majority of patients. And that's what we mean by cure. The tumor's out, it's no longer having an endocrinologic effect.
In that, where you mentioned that the cortisol goes to undetectable levels, how does that affect the patient, how they feel after surgery?
That's a great question. So in the immediate postoperative period, they feel really crummy, like having a terrible flu. And as bad as it sounds, we can, walk into a room, and if that patient feels crummy, I know they're probably cured because their cortisol's crashed. And we're tracking that very carefully as we're watching it crash down, and then we supplement them with steroid doses. And as soon as we see that and we get those biochemical values that tell us that they're cured, we supplement the steroids orally or through an IV, and the patient feels better within hours. And we get them to a normal physiology. And then over time, anywhere between 6 months and a year, we can wean those steroids off because their gland will start to function normally. But that patient feels just like they're just incredibly fatigued. They feel nauseated sometimes, and they just don't. They feel very weak while we're watching those cortisol levels decline.
Okay, a macroadenoma with ACTH has reoccurred and removed twice, but is supposedly non-functioning. Can they cause Cushing's disease later?
I have not seen that. I don't, the conversion of one type of adenoma to another. I've not seen data or cases where that's occurred. Now, saying that, adenomas can secrete two types of, so growth hormone adenomas and prolactinomas there are adenomas, I should say, that can secrete or stain for growth hormone and prolactin. I think it would be unusual for a tumor that didn't stain for ACTH to become an ACTH secreting tumor later on. I've not seen that.
Okay, thank you. Option of medical management.
So there is a number of agents that can be used. They have different side effect profiles, and that I would typically rely on the endocrinologist to give the best guidance if you're in that, when a patient gets to that state, because and it's highly variable depending on the patient. So there's no kind of blanket, you need ketoconazole or you need, X, Y, and Z. It's really dependent. It depends on male, female. It depends on childbearing versus not childbearing. It depends on, what the blood sugar levels are, things like that will guide that. But there are a number of agents that have been described, and it really becomes very patient dependent. But that medical therapy part is very helpful if surgery has failed and patients go to radiation. That medical therapy part, while the radiation is working, because it can take months to years to work, or 6 to 18 months to work, sometimes that medical therapy can suppress the effects of the cortisol hypersecretion.
Okay, thank you. Is there any role of SRS?
Yeah, so that's the radiation I'm talking about, and that's the role of SRS is after failed surgery.
Okay, and what point, how far, and how many different options do you try before bilateral adrenalectomy?
Yeah, so that's the question that keeps it right. So I can tell you, I don't think Ed or myself sent anybody for a bilateral adrenalectomy in over 20 plus years, and so I would exhaust medical and with the stereotactic radiosurgery first before moving on to the bilateral adrenalectomy. That's the last resort. It is effective. It does have complications, even with the laparoscopic forms, which have very much improved the patient comfort and things like that after surgery. But I would use that after SRS and as the treatment.
Okay, excellent. How often do Cushing's related tumors reoccur?
So it depends on the series, and I'll show that range. I just briefly skimmed over that. So here we go. These are series from the last 5 years. You see the numbers of patients here. Our series in this 200 was all pediatrics. We've not come out with our adult data yet. We're in the process of looking at that. But here you see the overall success rate of remission, and it ranges from 67% to 98%. And recurrence rate is highly variable as well. So you see recurrence rates here of anywhere between 7% and 60, or 5%, sorry, and 66%. And in our hands, it was about 7% with 7 years of follow-up. So it gives you kind of a gestalt. Part of the problem with these papers of surgical outcomes is not all of them use standardized biochemical, or not standardized, but biochemical remission criteria. Some of them were based on eucortisolemia, which means they didn't have that crash of the cortisol, and some people consider that successful treatment in some cases. So it's institution and surgeon dependent, to be honest with you, and you can see that reflected through this wide range of results.
Do you think that surgical experience or skill of the surgeon also plays a role in the remission rates?
Yes, I think it's one of the most critical roles, in fact. And as you could see from, dealing, if 50% of these cases are MR invisible, it's really and this is unique to Cushing's disease versus some of the other pituitary disorders, which are much more straightforward because you see a very obvious MR imaging positive tumor. But surgeon experience and expertise with this is absolutely critical. I think any pituitary surgeon that manages Cushing's disease will tell you that, because it's many of the cases we'll see we don't have the imaging evidence of the tumor, and we have to do a very discrete gland exploration and carefully identify that tumor and remove it. We don't have that scenario, though, in virtually all the other pituitary tumors we manage surgically.
Okay, thank you. Is there a reversal of clinical features after surgery?
Great question. Yes, there is. Some of the features are not as they are reversible. Unlike the growth hormone adenomas, where many of the features are not reversible, many of the problems associated with Cushing's disease are reversible. In fact, all of them are reversible, maybe not completely in some cases. But you could see, for the most important thing is the impact on mortality. We can completely reverse that by surgical cure.
Excellent. Okay, thank you. I think that does it for the questions. I don't see any more. Oh, wait. What about leg weakness? Does it reverse too?
Yeah, it does in time. Those are some of the more recalcitrant things. And remember, after a successful surgery with biochemical remission, the exogenous steroids are still being given. The pituitary gland is recovering, and that takes anywhere between 6 and 12 months to get free of that. So it's a process over time to return to a very normal state. And during that time, you're rebuilding your muscle strength and all of those types of things.
Okay, thank you. Any other questions? I don't see any more.
Great.
I'll give a couple more minutes.
Okay.
Okay, well, I think that does it for questions. This concludes today's webinar presentation. We appreciate you all taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website, www.pituitary.org, after it is edited. There'll be a brief survey after the webinar. Please fill it out and help us to provide you with the information you need. Thank you for joining us. Dr. Lonser, thank you so much for the excellent presentation. And we'll see you all next month. Enjoy the rest of your day.
Thank you for the opportunity to present.
Thank you so much. Take care.
Bye.
Bye.